I have the pleasure of introducing Dr. Mary Cushman. She is the Professor and Vice Chair of Emerging Researchers in the Department of Medicine and a Professor in the Department of Pathology and Laboratory Medicine at the University of Vermont. She's also the Director of the Thrombosis and Hemostasis Program at the University of Vermont. She is on the editorial board of several journals and is a very well-funded educator and is here today to talk to us about health disparities in VTE. Cushman, thank you.
Unmute. Can't hear you. Can you back up one?
Apologies for that. I think it should be good now.
Perfect.
Okay. Sorry, sorry about that. So these are my lack of disclosures. And I am an epidemiologist and hematologist, not a trauma surgeon, orthopedist, or neurosurgeon. I'm having trouble advancing my slides. There we go. So we're going to be talking about race in this discussion. And in this talk, the reference to race is in the context of understanding the sociocultural determinants of health. In some cases, I might discuss genetic markers or biomarkers that are more common or unfavorable in people of African ancestry, which in turn makes them more common in Black than white people in the United States. So I like to think about the usefulness of epidemiology studies to help inform clinical research and clinical practice. So findings from epidemiology studies, of course, can be transitioned into human testing and clinical trials or in implementation science settings. And what I'd like you all to think about is how the data I'm going to share with you might be used in your own research or your own clinical practice. What actions might you take based upon the information that I'm going to share? And the premise here is really that we won't have a clinical trial for every situation that we face in medicine, and we need to adapt knowledge to the clinical scenarios that we see every day. For example, how do you prevent VTE in different risk groups? So I think I don't need to spend much time on this slide. Everyone in this audience knows the importance of VTE and how common it is in the United States. You might not have thought about it this way, but the lifetime risk once a person reaches age 45 is 8%. It's just another way to think about how much this disease impacts people as they age. It explains some unclear number of deaths annually, probably around 90,000 annually. And the treatment complications are substantial, including major bleeding in 6% of people. And of course, there are long-term sequelae, as has been discussed before. It's important to note that over recent decades, the trends in hospitalized PE have been increasing. So when you consider PE in any position in a discharge diagnosis code list, there has been a tripling in PE occurring in hospitals. And when you consider PE as the principal diagnosis for the hospitalization, there's been a doubling. So this suggests that we're failing in many ways, although some of this could be due to the aging population. I also think this audience is familiar with the concept that risk factors combine together to bring a person across a threshold whereby they might develop a DVT or PE. And the risk factors include genetic factors and acquired risk factors like aging, cancer, elevated biomarkers, use of exogenous hormones, obesity, et cetera. And then things like trauma and surgery are the triggering risk factors. These are the really powerful, strong risk factors that raise the risk tens of folds for short periods of time after the exposure. So I want to share with you the story of what we know about racial differences in venous thromboembolism. And in terms of thinking about how to address this question, analysis of administrative data is a good place to start. And Richard White started doing this research in the 1990s and looked at California claims data. This was well before we had Optum and MarketScan and other types of resources to analyze. I gave him a lot of credit for kind of starting us thinking about this kind of research. But what he showed using claims data, hospital claims data, was that the incidence of VTE was higher in Black people than other groups, and leading to a rate ratio of 1.27, or 25% increased risk in Black people compared to white people. Further studies have shown that the consequences of VTE may also be worse among Black people. They appear to have a higher burden of pulmonary embolus than white people for reasons that are unexplained. They appear to have higher case fatality and higher readmission rate after discharge. So how can we think about the impact of this in our practice? I challenge you to consider that. Now, this slide is from a more recent study that I just really love from Carlin Martin at Northwestern University. And what she looked at is a database called CDC Wonder, where you can plot out graphs like this based on CDC data and in terms of the causes of death for different diseases. And so in this plot, she looked at PE as the underlying cause of death from 1999 to 2017. And I hope you can appreciate this. The two lines at the top represent Black men and Black women, the kind of pink and green lines. The shaded areas are the confidence intervals for these estimates of age-adjusted mortality rate. And all the lines clustered below are the overall population and white people separated out. So what you see is that very persistently over time, there is this disparity in death from PE affecting Black people. And the orange vertical bar is an inflection point, which it's a little hard to see with the naked eye, but statistically an inflection point detected in 2008, where PE mortality has been rising in all groups, similar to the slide I showed you previously that was suggested in the AHA statistical update. So you see this decline, and then this is actually a rise. So administrative data like this has weaknesses. There's a misclassification of case status and risk factor data. The availability of covariates to do adjusted analyses is limited, and the quality of those data is sometimes suspicious. We can't always address questions of etiology, like why are these differences apparent? And I've listed some potential reasons for these differences that we could ponder: healthcare attitudes, socioeconomic factors, risk factor susceptibility differences, neighborhood environments, structural racism, and maybe race-specific risk factors. So I'm going to give some examples of some of these. And to delve into this data, observational studies are really helpful. So observational epidemiologic studies or cohort studies. And a cohort study is where you enroll a large number of people and then follow them prospectively over time for the outcomes of interest. So in this case, a study with 22,000 people with extensive risk factor assessment, and then years of follow-up for VTE outcomes. And you can then relate the baseline risk factors to the outcomes. We pursued this study. We started something like 20 years ago on the LIGHT study, the longitudinal investigation of thromboembolism etiology, which utilized 2 cohort studies funded by NHLBI that were originally designed to study cardiovascular risk in middle-aged and elderly people. And Aaron Folsom and I have been collaborating on this and utilized this data resource to ascertain VTE events in these 2 cohorts, now with decades of follow-up available, a few decades plus of follow-up available. This shows data from our first analysis looking at racial differences in VTE in the LIGHT study. And in this analysis, which I think included about 400 and some cases of VTE that occurred after baseline, we were able to show a higher incidence of VTE in Black compared to white participants. And you see the hazard ratio there of 1.6, which was adjusted for other risk factors. And as I was prepping this talk, I was thinking, I wonder if the trauma community is aware of these differences. I've heard a little bit about this earlier today, and I just want to make sure you know about this. Interestingly, the hazard ratio was slightly higher for provoked than unprovoked VTE, suggesting perhaps all kinds of hypotheses about possibilities for reducing these racial disparities through preventing provoked VTE, like trauma-related VTE or surgery-related VTE. Later on, we developed this kind of lifetime risk concept as another way of looking at this. And Pamela Lutzy at University of Minnesota led this work. And basically, when you look at the impact of this and how we can think about this from a practical point of view, after age 45, for a white person, their lifetime risk of VTE is about 7%. And for a white person, it's 11.5%. So it just gives you another way to think about what these hazard ratios actually mean in clinical terms. As far as I'm aware, I'm not aware of data on racial differences in the incidence of VTE in trauma patients specifically, or on racial differences in effectiveness of prophylaxis. I looked at a few sort of randomly selected trials and didn't notice that all of them even reported what the race composition of the participants was. And it makes me wonder as well, because we know this is a rampant issue across all kinds of clinical research, of whether racial minorities are adequately represented in these trials. And so data like this would be highly relevant to the work that you're going to be doing here tomorrow to try to reach some consensus and identify research gaps and plans for the future. So I think I've shown you there's racial differences. We have little understanding of the reasons. There are several hypotheses that are shown on this slide. Compared to white people, Black people do have a lower prevalence of the common known genetic thrombophilias, so that wouldn't seem to be a reason for these differences. They have the same likelihood of a positive family history, sort of suggesting the same thing. But they have more adverse levels of a number of hemostatic factors like D-dimer factor 8, protein C, thrombin generation. And the age-related increase in D-dimer in healthy people is greater in Black people than white people. It's one of those papers I have never gotten to publish, but I should. So what kind of hypotheses can we really consider in terms of reasons? There could be differential susceptibility to risk factors. There could be different prevalence of risk factors that might mediate this racial difference. And there could be race-specific risk factors. On the susceptibility point, it's pretty easy. We looked in the LIGHT study at biomarkers of thrombosis risk. We've looked at a slew of different things. And we did this using a study design called a nested case control study, where you pull samples out of your biorepository storage on people who developed VTE and select a control group and measure those bioassays in that subset rather than in all 22,000 people, which isn't fiscally responsible. And this slide just sums up some of the major risk factors that are measured in biological samples, and really showing there's no difference in their relationships with VTE by race. And even a suggestion that factor V Leiden might be a stronger risk factor in Black people, although that wasn't significant. So we'll move on to mediation analysis. Are there mediating factors that we can identify for the racial differences? And Neil Zakai pursued this work in this really nice paper where he looked at the Black-white hazard ratio. And in this analysis, he separated the ERIC study and the CHS study. ERIC is middle-aged people at baseline, CHS people 65 and older at baseline. And you see, again, the hazard ratio I showed you before, associated with Black compared to white race. And when body mass index is added to the model, you explain 30 to 35% of the racial difference. So what that tells us is that differences in adiposity are a really key factor in these racial differences that we see. Now, we did a further update on this with later follow-up. Aaron Folsom led this analysis, and it's a little different follow-up period, and I won't get into the reasons why, but in this analysis, we have an overall hazard ratio in the ERIC study with longer follow-up that was larger. It was twofold increased. And when weight was added to the model, there was a 21% reduction. Fascinatingly, when income was added to the model, there was a 26% reduction. And when factor 8 was added to the model, factor 8, which is known to be higher in Black people, there was a 20% reduction. So this gives us clues as to important factors that mediate this. And when you put all three of those factors in the model, you explain 3/4 of the racial difference. So almost all of it that can be explained statistically. And so this gives us ideas of what we might do in our practice to reduce these disparities. Look at income. People in lower SES groups are at greater risk. And a very important thing for you all to think about. So essentially, I think I've shown you that Black people have a higher risk and higher burden than other groups, including for provoked VTE, that risk factors explain a lot of this. Some of it is unexplained. And you can come up with many ideas. You probably have your own ideas, but I have some ideas of how you might apply this in your research or practice. Is prophylaxis adequate in trauma centers that are serving poor people? Could structural racism be at play? Are clinical trials inclusive? Is race reported even in our trials? These are things we need to know. Race-specific risk factors, I'll give you an example here of a potential one, sickle cell trait. So sickle cell trait is present in 8% of Black people in the United States. We know that both sickle cell disease, hemoglobin SS, and sickle cell trait, hemoglobin AS, are hypercoagulable states. People who have these disorders have higher levels of D-dimer and F1.2, for example, and that sickle cell disease increases VTE risk, especially PE. And this is hypothesized to be due to hypoxia and slow flow in the venous valve sinuses that might induce sickling regionally and contribute to clot formation. So in the LIGHT study, you can see here the incidence of VTE based on whether sickle trait was present amongst the Black participants. And you can see that sickle trait was associated with a 60% greater risk of venous thrombosis after adjusting for age, sex, and African ancestry. So this level of risk, it's pretty similar to the risk related to birth control pills or postmenopausal estrogen, and it's occurring in a population with a higher baseline risk and higher obesity prevalence. So remember that slide I showed you where the risk factors all come together to cross a threshold, that it has relevance potentially in these people. From the absolute risk perspective point of view, Pam Lutzy's sort of concept. So overall, our lifetime risk after age 45 is 8.1, Black people 11.5, with obesity 11, with factor V Leiden 17, with sickle cell trait 18. 1 in 5 people with sickle cell trait will get VTE in their lifetime after they reach age 45. Helps us just to conceptualize this. Here's this put another way from the point of view of thinking about surgical risk. I've plotted the relative risk on the x-axis here and the people with sickle cell trait or not on the y-axis, and showing the hazard ratio just in general if you have obesity, then if you add, say, postmenopausal estrogen or contraceptive use, and then if you add surgery. So you see how surgery is such a massive risk factor, but it amplifies the baseline risk of the patient. So you can get risks, for example, after surgery, up close to 100-fold greater with this combination of risk factors. You could translate to absolute risk. If you were considering a woman who was 60, this could translate into a risk as high as 25% over several weeks after surgery, for example. Can we act on this in trauma care? It's a little difficult with sickle cell trait because there's low awareness of carrier status. But if you ask about family history and someone tells you they have a family history of sickle cell disease, you might be able to think about this. But a lot of people who are carriers don't know that they are, unfortunately, even though we have newborn screening in this country. You can think about that for a moment and why that is. So to summarize, again, VTE is more serious and prevalent for Black people. It might be mediated by obesity, lifestyle, socioeconomic factors, maybe structural racism, maybe income is intertwined with structural racism, maybe efficacy of thromboprophylaxis, we don't know. Differences in coagulation factors, perhaps, factor 8, sickle cell trait. There's a lot of ideas here to think about. So I'll go back to the research to practice challenge, thinking about taking information from epidemiology studies and applying it in your work, in trials or in implementation science studies, or just in your day-to-day practice. And what can you do? So you could make sure you include underrepresented minorities in trials. During the pandemic, I was fortunate to get involved in working on COVID trials with, I think, several people who are in the room here. And we were very intentional in trying to include underrepresented minorities, and we were successful. About half the participants in our anticoagulation trial in COVID were underrepresented minority participants. So it can be done if you're intentional about it. Report the results for underrepresented minority people in observational studies and clinical trials. Just tell us who the people are in your studies. Study racial differences in VTE after trauma and work to improve systems of care for prevention and diagnosis in trauma patients living in minoritized communities in particular. And then consider the role of unconscious bias in healthcare. Are we applying treatments similarly? Is there any reason why we might not be? And always ask yourself that. So to summarize, to improve clinical care, I think drawing on information from all sources is beneficial. Epidemiology and implementation research are important. And I hope I've shown you that there's opportunities for the trauma community for new research on race differences and racial disparities. Even just a simple review of the existing literature, I think, would fill a gap in our understanding. I would like to thank just a few key people who worked on the LIGHT study here at UVM and other institutions, acknowledge our funding for many years for this work from NHLBI, and I'd be happy to take any questions you might have.
Any questions for Dr. Cushman?
Peggy Knudsen from San Francisco. Thank you so much for a very interesting talk, and it's interesting that we have a very large database focusing on DVT, PE, and PT in trauma patients. And we were asked if we collected race and ethnicity, and we did. So we have about 8,000 patients. If you would like to be working with us on that, we'd appreciate your expertise. Thank you.
Yeah, I noticed that in your presentation earlier, which I really enjoyed, by the way, especially your call out to Steve Shackford from the University of Vermont. But absolutely, I'd be happy to help if I can be helpful.
Dr. Cushman, it's Lucy Kornblith. I am just curious if you can comment a little bit on response to prophylaxis and treatment that is racially based, since we know that For example, in antiplatelets, there's genetic differences that contribute to how people respond.
You know, I don't think we have answers to that. And part of the problem is clinical trials, if you wanted to look at the hard outcomes, right? Clinical trials never have enough non-white participants. It's just the fact of the matter. I know, for example, the American Heart Association is about to give out tens of millions of dollars to research groups that will address how to increase participation of health disparity groups in clinical trials. So I think from the point of view of secondary analysis of trials, it's very difficult to do because you don't have enough representation. I think it would be fascinating to see if factors such as circulating biomarkers might impact the responsiveness to anticoagulation by surrogate measures, you know, but, you know, and when you think about trauma patients, and it's not really my area, but I think the work you're doing is really important in trying to clarify whether there are, you know, surrogate endpoints that might be relevant. I don't have an answer though. But I hope a few people in the room decide they want to work on that because it would be really cool.
Thanks again, Dr. Cushman. Again, a really fantastic talk. We appreciate you joining us today.